morning, everybody. It is my privilege to extend a very, very warm welcome to each of you present here this morning, and many of you have traveled across the globe to be here. On the 11th of March 2020, WHO declared COVID as a global pandemic. It suddenly stopped life and changed it in a way that we never knew, that we were never going to go back to the old ways on many fronts. Overnight, what we took for granted in terms of travel, in terms of sport, in terms of, globalization, in terms of making sure that everybody was well and all of us expected to live to the 80s and the 90s, suddenly changed. Little did we know that the proportions of this pandemic and the spread would assume over many months that it followed would change the lives for many forever. Many lost lives, lost livelihoods, well-being. And what happened in that year and a half over several waves, so unexpected, can never be truly quantified or identified. What we knew and what would come together and what we could identify, that these flight and fright responses need to be collectively fought, and a collective response deserves concerted efforts to learn continuously from the gaps exposed across the systems and from adaptive innovations to counter these shocks. With a vision to bring together the multi-regional health systems actors and stakeholders together in strengthening our collective response to health shocks and other adverse global events, was born the Global Learning Collaborative for Health Systems Resilience on the very day that the pandemic was declared, 11th of March 2022. So we are here exactly 2 years later from the WHO declaration to ensure that we learn together and grow together to face these crises as they do happen and not forget what we already have. The GLC4HSR, as it's called fondly, is a global platform that facilitates the practical reciprocation of knowledge and sharing of co-creation of effective health systems transformation strategies amongst so many countries. The GLC4HSR brings together people and institutions across geographies, across multiple levels, together to nurture a culture of learning, adapting, and achieving transformation. This initiative brings together a network of health systems experts, practitioners, policymakers, with a vision to build back better, and of course, the civil society to build back better. More resilient health systems as we go into the next phase, hopefully post the pandemic, into the world. This journey has been unique. We have grown both in depth and in width, and we now have representatives from 17 countries. Our illustrious panel and advisory members are testimony to that. We have embarked upon several learning journeys over the past year, and the annual Conclave will bring together dissect, deliberate, and refine upon these ideas through technical sessions that are lined up. Some of the housekeeping rules are: you will be often provided with a QR code and polls. Please do answer them. It will give us feedback on going forward and how we can take the next steps. I welcome you all again and thank each one of you who have taken time off from very busy schedules, flown halfway over the world to become a part of these discussions face to face. We are indeed privileged to be meeting face to face after such a long gap. I now call upon Dr. Krishna Reddy to please take the dais. Dr. Krishna Reddy is a practicing senior cardiologist, regional director, South Asia, Access Health International, the president of InOrder Health Systems, and an associate and a cardiologist at heart. He co-founded Care Hospitals in 1997, a chain of tertiary care hospitals located across the states. And in the course of his illustrious career, he has taken on many, many roles, more as an entrepreneur, as a giver, as a public health expert, and of course, as a private healthcare provider. Dr. Reddy joined Access in 2018, and he leads us to strengthen this as we go over. I'd like to bring our keynote speaker, Dr. Manoj Jilani, who actually needs very little introduction to this audience. But Dr. Manoj Jilani is the Director of Health Systems Development, WHO, Regional Office for Southeast Asia, New Delhi. In the past, he has been a member of the Indian Administrative Services. Between March 2012 and November 2019, he served in the Ministry of Health and Family Welfare, Government of India, as Joint Secretary, Policy, and later as Mission Director, National Health Mission, while holding the post of Additional Secretary and Special Secretary to the Government of India. Between 1987 to 2012, he served in the sub-district, district, and state-level planning, designing and implementing policies and programs in the social sectors, the state of Madhya Pradesh, India. He pursued an MBA from Public Service from the University of Birmingham, a BTech from the Indian Institute of Technology, Kanpur, several awards to his accompaniments and his credit, and the UNITAF award to his contribution towards addressing NCD challenges in India. He recently supported the launch of the Primary Healthcare Alliance that is going to take us down to the last mile across 8 countries and the region, Southeast Asia region. A privilege to have you, Manojji. Our chair and president, William Hasseltine, a scientist, a businessman, an author, and a philanthropist, and probably an encyclopedia on any subject that you touch him. He can take you down to the very depths and teach you how to take it forward. A professor at the Harvard Medical School and the School of Public Health, and the founder of the university's Cancer and HIV research departments. He's well known for his pioneering work on cancer and HIV/AIDS and genomics. He's founder of more than a dozen biotechnology companies, including the Human Genomic Sciences. Authored more than 200 manuscripts in peer-reviewed journals and more than a dozen books on health systems reform and infectious disease. His passion to bring the best practices across the globe and reach out to every citizen that he thinks that we can touch through our health systems is one of them that infects us and keeps us together. I have Dia Samarinish, I don't know if I pronounce it right, and founder and CEO for the Center of Indonesia's development initiatives called SISTI in short. Dia is an Indonesia's development practitioner and is a public health advocate, and currently the chairwoman of the Board of Trustees and CEO of Public Health Non-Profit for the Center of Indonesia's Strategic Development Initiative, CHISTI. A psychologist by training, and her professional journey has grown across consulting for companies, government, national public health institutions, multilateral organizations. Currently concluded her role as the senior advisor to the WHO Director General on Gender and Youth. Has received several awards for social innovations from Economics Intelligence Unit, and also the recipient of the Global Award from the Open Government Partnership for the Improvement of Public Service in Primary Health. May we have you up here, Dia. I next have another illustrious person to bring up, Professor Mushtaq Chowdhury, advisor, James B. Grant School of Public Health, BRAC, University of Bangladesh. BRAC University, Bangladesh. Ahmed Mushtaq Raza Chowdhury is a development worker and researcher, academic and microphilanthropist. He spent several rounds and around 4 decades with BRAC, the world's largest non-governmental organization or foundation. He was its vice chair, executive director, and now the founding director of the Research and Evaluation Division, which is merged with the Graduate Institutes of BRAC University, and the founding dean of the James B. Grant School of Public Health. Professor Chowdhury is also a professor of the Population and Family Health at the Columbia University in New York. He's received several prestigious awards, the Medical Award for Excellence, bestowed on him by Chicago-based Ronald McDonald House Charities in 2017, amongst others, and has already been honored by the Lancet for his contribution to global health in 2013. A privilege to have you here, Professor Mushtaq. Dipali, my very own, and our partner in crime, who has helped seed the entire Global Learning Collaborative, and the wind beneath our wings. The Vice President, Asia Region Office, the Rockefeller Foundation. She is responsible for the Foundation's policy, advocacy, grant-making, partnerships in Asia, and leads the Rockefeller Foundation's initiatives to convene and catalyze strategized collaborations that advance development in Asia, as well as harness Asia's role in chat and be the well-being of humanity in the region and around the world. She serves as the director and managed one of the Foundation's flagship initiatives in India, Smart Power for Rural Development, SPRD, where she provided leadership and direction across the full range of activities, partners, and resources, enabling affordable and clean energy across to over 1 million people in India. I request you to be here, Dipali. And if you heard me for the last 5 minutes, all these people's, achievements have been summarized to less than 100 words, and each would actually fill a few pages, if not half a book. So it is indeed a privilege, and I would like to give everybody a big round of applause for being here with us today. I now hand it over to Dr. Reddy to take forward the session. Thank you.
Thank you, Uma. And on behalf of Access Health, It's my privilege to welcome all of you and also welcome all of you. I keep describing GLC with whoever tells, both Rockefeller Foundation and Access Health, we are parents of GLC, and this is the first birthday. So it was conceived in August 21 and took birth, as Uma mentioned, on March 11th. So from our own perspective, our team's perspectives, and the Rockefeller family perspective, this is a momentous occasion to present briefly what it is, what the Global Learning Collaborative is, and what happened in the last 12 months, and what the journey it is looking forward to in the future. The purpose is not different. I think everyone in this hall who are part of GLC, either as members or as partners or as well-wishers, I think all of us want health for all at all times. I think that's the shared purpose. The only thing is each one of us take a different approach, a different path, a different route to achieve the same thing. But many a time we don't bring all these paths together. So that has been the key objective of the collaborative, that can we bring people together? Can we bring organizations together? Can we bring different departments within a government together? Can we bring the researchers and the practitioners together? I think it is more a journey taken together by all of us. So it does not belong to anyone, it belongs to everyone. The key hypothesis of approach as a collaborative learning of the GLC is that knowledge and learning is a powerful tool to transform systems. I mean, some of us focus on actions, some of us focus on knowledge. What GLC attempts to do is to pool the knowledge from all of us sitting here and people sitting outside, and curate to filter what are actionable insights from these experiences and the knowledge that sharing happens. And then can we translate those actionable insights into actions? So this virtuous cycle of knowledge to action and action to knowledge. I mean, in our Gita philosophy, we say the two pathways, the Jnana Yoga and the Karma Yoga. That is the pathway of knowledge and the pathway of action. Both are equally important, and both have to integrate and with each other. So this is the premise on which the GLC is founded, that the process of the learning, I mean, we should enjoy this process of learning as we go forward. And then this learning, if it can implant an idea into a policy maker, an idea into a leader, organizational leader, a systems leader, and that idea can multiply. I mean, unlike the COVID virus, if a good idea multiplies, the good results. So that is the hope, that these learnings should lead to actions, and the actions should lead to learnings. I think so. That's the future of the GLC in terms of how we would like to approach. In addition to the learnings, by bringing together different people around different themes and the sub-themes of depending upon each one's interest. So that is one way of organizing the GLC, the group. We adopted 3 guiding principles. In fact, we shared with Manoj Jalani and Mek when we had an interaction, that the GLC should be self-organizing around themes, sub-themes, around geographies. It should evolve. I mean, we should not engineer and put a frame to it. It should evolve organically and iteratively so that it expands across the geographies. And it should be self-governing. That means there should not be any single agenda, single direction, that it has to govern by the members who are part of the GLC or the well-wishers and the partners who are part of the GLC. So it's a self-governing model. And the third is it should be self-sustaining. The seed capital came from the Rockefeller Foundation. But around that, the people's time, people's knowledge, people's wisdom, people's experience, that is invaluable, along with the money. So what GLC expects from all of you, sitting here and sitting outside, is your volunteering your time, your knowledge, your wisdom to this effort. And some of you may also take the onus and the ownership of taking it to your own countries, your own states, your own districts. The idea is to take these channels through which I always apply the analogy of a river. The purpose of the GLC is the ocean towards which the river is journeying. And the different streams join to make it bigger. And some streams branch out to irrigate the fields of the health systems. So these channels should become a kind of a boats taking the knowledge to the grassroots level. And then again, there is a rich experiential wisdom from the grassroots level which can be taken to the global level. So that connectivity from the global, which is 30,000 feet high-level concepts, how we can translate into things which people can experience. So that should be the objective of the GLC. When it expands into the country chapters, the state chapters, the district chapters. In fact, two of the people sitting here, Dia and Mustaq, we have the champions. I mean, they both volunteered that they can champion the GLC in their respective countries. That means the Bangladesh chapter and the Indonesian chapter. Similarly, we are in talk with Dr. Somsak of the National Health Foundation in Thailand, whether the National Health Foundation can take the onus of expanding the GLC in Thailand. And some of the speakers who are here, actually some of them are already volunteering that can they nurture this GLC in their own respective countries. That is what we expect. I mean, ultimately, each one should champion in their own country, in their own state, like the University of Hyderabad would like to champion in the state of Telangana. Because the context will be different, and the same financing may be different, what it connotes at a village level, at a district level, at a state level, at a country level, at a global level. The same financing topic can be discussed at different levels. So that's the objective of the GLC, that it has to expand from a global to the local level. And that is where we can complement, in fact, we can support some of the global bodies. For example, Manoj Jalani is sitting here. Ultimately, the WHO is the director of the global health systems, and they are the guide force. They are the source of knowledge reports. But each one of us can complement the WHO's efforts in translating some of those knowledge resources, some of those key tools that the WHO brings out for the country's benefit to the grassroots level. So we need organizations to take them to the grassroots level so that we can strengthen these global governing bodies. So these are some of the objectives of the GLC. Just I wanted to give it as an opening remark so that a lot of you may not have a comprehension what exactly is GLC and what is the direction of GLC. So what is going to be discussed in the next 2 days with all of you, it is designed as a kind of open dialogue, least presentations, just express whatever you feel like on a given topic and a given question. But some of us will be curating that and trying to see what idea is actionable. And some of the ideas we are still ambiguous. In fact, the very concept of governance, we are still fluid. It's still ambiguous. Is it government? Is it people? Is it private sector? Who is governance? So some of these concepts which are not yet clear, I think these deliberations in the next 2 days should clarify what actually these ideas are and clarify to a language which can be understood by non-experts. Because most of the dialogue happens among the experts. But there are many non-experts here. There are many civil society representatives are here. We forget that the people need to understand what we are talking. So how this dialogue can be translated into a language which an ordinary person can understand, I think that should be the objective. And some of the thoughts, some of the ideas which left unfinished during this conference, the journey continues. This is only a stop, a milestone. And the journey continues in the coming months and the coming weeks as a part of peer-to-peer learning sessions, the focus group discussions, and then culminating in the next anniversary birthday, that is next year, that again all these ideas can be brought together. In fact, this conclave is designed based on the learnings and the discussions and the dialogue that happened in the last 1 year amongst the members, amongst the special interest groups, among the experts from different parts of the... So this, we expect that it can be taken forward. So with this, I think a few words and the introduction. I hope all of you will enjoy the process of learning. So I won't say, sometimes it may be boring, but sometimes it may be exciting. And also there are enough time for all of you to, because there is enough break between the sessions so that you can carry forward the discussions between individuals and between the groups. So with these few words, I take rest and I thank again on behalf of Access Health, on behalf of the family of the Global Learning Collaborative. Welcome you all for this 2-day conclave. Over to you, Uma.
It's our proud privilege, Manojji, to please ask you to come and address our gathering. Do you want to connect to?
No, that's fine. Dear Dr. Krishna Reddy, Dr. William, Dr. Uma, Ms. Dia, Professor Mushtaq, Ms. Deepali, friends, colleagues, good morning everyone. I'm truly honored to address this August gathering of the first annual conclave of the Global Learning Collaborative for Health Systems Resilience. The development of the Global Learning Collaborative and this first annual conference comes at the right moment, a moment where the imperative to learn and work together has never been greater, a moment when countries are, and indeed should be, looking for answers and best practices to build resilient health systems as part of building back better, based on the COVID experience. There is a strong need to bring the best evidence to practice globally. Despite our collective experience with public health emergencies, COVID-19 demonstrated that national health systems, even in rich countries and even in countries that ranked high on International Health Regulations 2005, were poorly prepared for a pandemic of this scale. COVID-19 exposed the weaknesses in health, economic and social systems worldwide, with countries experiencing significant disruptions and massive loss of lives and economic losses due to pandemic and response efforts. However, the experience and the response also provided very useful lessons and innovations to prepare for any future pandemics. The WHO estimated all-cause mortality, that means direct due to COVID and also due to non-COVID reasons, to be 14.83 million in years 2020 and 2021 together. That means 1st of January 2020 to 31st December 2021, which is 2.74 times more than the reported COVID mortality. Possibly, the indirect deaths associated with the health and social service disruptions and economic breakdown could have surpassed those directly caused by the virus, highlighting the importance of resilience and maintenance of essential health services and functions. We have seen that when health is at risk, all other sectors are at risk. Issues beyond the health sector, such as changing demographic patterns, climate change, changing land use, deforestation, and increased animal-human proximity, coupled with increasing population density and globalization, are increasing the likelihood of further pandemics or other crises. We have noticed this in the last 2 decades, that incidence and severity of health emergencies is on the rise. Given the massive return in terms of avoiding future economic and social losses, investing in resilient health systems that ensure ability to protect and promote health and maintain essential health services even during a crisis should be the foundation of social, economic, and political stability. The Global Learning Collaborative for Health System Resilience purpose, mission, and vision are timely. There is a significant political commitment to build resilient health systems. There is also a real danger that the cycle of panic and neglect may be repeated with geopolitical crisis, fiscal stress, and decreasing COVID infections and mortality pushing this critical priority in the background. COVID has driven home this message loud and clear, that the cost of action is far smaller than the price of inaction. We saw that during COVID. The WHO Council on the Economics of Health for All estimated that addressing gaps in pandemic preparedness and response represents just 1% of the price of inaction. So there is a real need to build resilient health systems, and there is a need for knowing how to do it. This is essentially what your collaborating is trying to facilitate. This is what the WHO is trying to facilitate globally, and I congratulate the Access Health and Rockefeller Foundation for this very important effort. Your efforts are especially well aligned with the WHO perspective at both the global and regional levels. The WHO headquarters came out with a position paper in October 2021 on building health system resilience for UHC and health security during COVID-19 pandemic and beyond. Not only that, all the regions, including CRO, came out with their own publications focused on building resilient health systems. Our Asia Pacific Observatory, Euro Observatory launched the Health Systems Response Monitor to capture the health systems response of different countries globally to COVID-19 to provide useful learnings on what worked and what didn't. I'd like to draw your attention to WHO's 7 interrelated policy recommendations contained in its position paper on building health system resilience for UHC and health security, and these are as follows. Leverage the current response to strengthen both pandemic preparedness and health systems. 2. Invest in essential public health functions, including those needed for all hazards, emergency risk management. 3. Build a strong primary health care foundation. 4. Invest in institutionalized mechanisms for whole of society engagement. 5. Create and promote enabling environments for research, innovation, and learning. 6. Increase domestic and global investment in health system foundations and all hazards, emergency risk management. And 7. Address pre-existing inequities and the disproportionate impact of COVID-19 on marginalized and vulnerable population. This was in October 2021. Now, with respect to WHO Southeast Asia region, the GLC is closely aligned to our 2 regional strategic documents that resulted from deliberations on learning from COVID-19 and decision of ministers of health of the region. These include the CRPHC strategy with its set of 7 values and 12 strategic actions. And central to this regional PHC strategy is the recognition that features of high-performing primary health care are the same as those required to address the growing challenges facing us, emerging and re-emerging infectious disease threats, escalating climate events, and the growing burden of NCDs. I also would like to draw attention to Strategic Action 12, emphasizing the importance of institutionalizing learning systems for PHC, including through building institutional partnerships in this respect. The second document is Regional Strategic Document, Strategic Roadmap on Health Security and Health System Resilience for Emergencies. 2023 to 2027. After all the emergencies in Southeast Asia region, we have had and sustained the practice of conducting a thorough lessons learned exercise, and the new roadmap for strengthening health security in the next 5 years incorporates those lessons learned. I also applaud the approach adopted by Access Health and Rockefeller Foundation in building this GLC on the very significant innovation and learning that is taking place in Asia, with the aim to expand it to the global level rather than an approach that is built elsewhere and then directed to Asia and other LMIC context countries. I note that the first 3 national offices of GLC are situated in China, India and Singapore, with strong representation in the agenda across Asian countries, where so much of innovation is taking place and is of relevance globally. I'd also like to take this opportunity to thank Access Health and Rockefeller Foundation for both helping conceptualization and launch of the SEER PHC Forum. Dr. Krishna's suggestion of the forum being self-evolving, self-governing and self-sustaining guides our regional PHC Forum. Launched last year, the SEER PHC Forum is bringing together a variety of development, implementation and knowledge partners under the leadership of the Ministries of Health of different governments to collectively capture learning, enable synergy and drive action on the member state identified bottlenecks on primary health care. And the discussion during this first GLC annual conclave is therefore highly relevant to the work of SEER PHC Forum. Let me also take a few moments to reflect on learning and opportunities for strengthening health system resilience as organized by the Building Blocks Framework. We are well aware of the WHO identified 6 interconnected components or building blocks of health systems, and these include the pillars of leadership and governance, service delivery, health workforce, medical products, vaccines and technologies, health information systems, and health financing. Across these pillars, people and communities are and must remain at the center. I'd like to share a few reflections on the importance of investments concurrently in all the health system pillars to pandemic preparedness and building resilience. On the pillar of leadership and governance, countries that had strong leadership and well-established mechanisms to work across sectors and engage with communities at both national and subnational level were better positioned to mobilize the whole of government and whole of society response to the pandemic. Of similar importance, community trust was the key factor for effective risk communication and public compliance. Government stewardship is also critical to build sustainable partnerships with private sector, particularly to drive innovations. During the pandemic, we saw successful examples of collaborators unifying the public and private sectors and working successfully at scale. Vaccines and diagnostics were developed and manufactured at an unprecedented scale. By further improving governance and government stewardship, we can optimize available resources for better health outcomes and pandemic preparedness. With respect to the pillar of service delivery, major gaps and underinvestment in the service delivery system were exposed by the pandemic, particularly during the Delta wave. Gaps in health infrastructure, hospital beds, laboratory capacities, medical equipment including ventilators and oxygen supplies, and health workforce were evident across countries. Unnecessary overcrowding at tertiary and secondary levels care was also very prominent. At the same time, we saw that countries with sustained investments in primary health care, bringing health system closer to the communities, were able to more quickly identify cases and mount an effective public health response. As an illustration, the recent WHO Universal Health Preparedness Review identified decades of sustained investment in a PHC-focused model as central to Thailand's COVID response. Moreover, the last 2 years saw a leapfrogging in the use of digital technologies to further strengthen service delivery, including telemedicine, telediagnostics, and doorstep delivery of medical products, which hold great potential for the future. On the pillar of health workforce, we in Southeast Asia region have prioritized health workforce strengthening as part of our regional flagship since 2014. The availability of doctors, nurses, and midwives has indeed increased over 30% during this period, and this was crucial during the pandemic. Indeed, teams of health professionals, students, retirees, traditional health workers, and millions of community health workers and volunteers were at the heart of pandemic response. Moving forward, it's essential that we further capacitate and support the array of health workers available in the region with a focus on delivering essential health services and public health functions. Lessons of mobilizing surge capacities for clinical care and public health functions need to be institutionalized. Next, on the pillar of medical products, vaccines and technologies. During the pandemic, we observed supply chain disruptions and stockouts of key essential diagnostics, therapeutics and devices that negatively impacted the emergency response and essential health services. Countries with robust systems for demand forecasting, procurement, quality assurance and supply chain resilience were better able to procure medical products at affordable prices and distribute equitably. There is a need for global collaboration for the R&D and manufacturing of medical countermeasures, that is vaccines, therapeutics and diagnostics. The pandemic also brought to the world's attention inequities in access to and financing of COVID-19 tools. The values of equity and solidarity need to drive long-term investment and partnership in this area. No one is safe unless everyone is safe. This lesson should not be forgotten. The speed and scale at which COVID-19 vaccines were developed, manufactured, rolled out and scaled up globally have been unprecedented and also speaks to the possible. I was talking to the CEO of CEPI, and the new global goal of CEPI is of 100 days to deliver vaccines against any new pathogens, from a timeline of almost 7 to 10 years earlier. Moving on to the health information systems pillar, the last 2 years of pandemic have shown us 3 years nearly, have shown us the criticality of reliable and timely information on health determinants, health systems performance and health status for effective, timely and calibrated response. However, this is only possible with robust information system that generates, analyzes and utilizes actionable health information. At the same time, pandemic exposed the fragmentation of health information systems. Moving forward, strengthening the quality of routine health information system, including surveillance capacities and strengthening processes for evidence-informed use of data at the local, subnational and national decision is critical. Effective use of digital technologies can significantly transform the quality of data and reduce fragmentation of information systems using interoperable data systems. We also need to strengthen the transparent and trusted mechanisms to share the data and information across the borders, which become critical because pandemics or viruses recognize no borders. As regards the financing pillar, we know that without financing there can be no health system, and even before the pandemic, the estimated annual financing gaps in primary health care for 67 LMICs were estimated to cost $134 billion per year, rising to $371 billion by 2030. Countries in our region, Southeast Asia region, have the lowest public spending on health, contributing to the highest out-of-pocket expenditure amongst all WHO regions. COVID-19 and subsequent economic shocks, compounded further by the recent geopolitical crisis, has led to rising debt levels and inflationary pressures, reducing fiscal space and hampering recovery. Decades of progress in service delivery, emergency preparedness and poverty reduction have either stalled or reversed. Despite challenges of fiscal space, additional domestic resources for health, including through pro-health taxes, are needed. At the same time, now more than ever, it is important to enhance efficiency and equity-focused targeting of health budgets. The crisis offers an opportunity to undertake difficult health financing reforms for improving efficiency and equity of government funding. We must recognize that public health is ultimately a political choice. Public health policymakers have to elevate the level of health in public and political discourse, as there is a real risk that even the lessons of this mammoth pandemic may go unlearned and the cycle of panic and neglect may be repeated. Political leaders now need to make resilient health systems central to their thinking about the future. Finally, I'd like to reiterate that there is only one health system. The same health system that will advance UHC will provide health security. One critical learning is that the health systems suitable to advance UHC sustainably are also suitable for health security. We strongly advocate for reorientation of health systems towards primary health care because that will advance sustainable UHC, health system resilience and promote well-being and help achieve health-related and even non-health-related SDGs in the most cost-effective and equitable manner. I'm sure this conclave would provide a collective opportunity to advance collaborative learning and action for building resilient health systems through PHC-oriented transformation. I thank the Access Health International team for inviting me to this event, and I wholeheartedly wish the GLC for Health System Resilience all success for this annual conclave and in its future journey ahead, and will look forward to receiving the executive summary of the recommendations. Thank you so very much. Have a nice day.
To hear you speak and share the journey that we have taken and also the way forward. I'd request our Chairman and President, William Hasseltine. Would you want to speak from there? It's a little small and tight, the stage.
It's a great pleasure to be here, especially see this vital and interested audience. I'll give you a little bit of the history of access, of my own history, and talk about some of the things I see coming for the future. I'm fundamentally a research scientist, educated by some of the great masters of our time. My PhD mentor was James D. Watson, the discoverer of DNA. David Baltimore was my postdoctoral mentor. And Baruch Ben Asaraf was my boss at the Dana-Farber Cancer Institute at Harvard. So I had the privilege of working directly for 5 Nobel Prize winners, all really interested in the fundamental questions of life, but also advancing human health. And it was a great privilege for me then to share that knowledge and to participate and to learn. To learn from them. That's to wake you up. One thing as a young scientist, it was tremendously interesting to be involved in that. And science has continued to grow and develop. And I can tell you, I'm a pretty close observer of science. Those of you who get my newsletter know I write almost every day about some amazing topic. And to be involved in the world of science and medicine today is like having a Christmas gift every morning. I wake up for this morning, for example, I went through summaries of research. And every morning there's some phenomenal new story, usually 3 or 4. It has to do with health systems, or it has to do with the new discovery, profound discoveries of how our bodies work, how that knowledge can be applied. This is an age of maximum opportunity, unlimited opportunity in a way. Just mention a few things. One that everybody here is familiar with is digitization of health. How is that going to impact health systems? Profoundly. Telehealth, profoundly. But at every level of the way our technology and our science is moving forward, we have enormous opportunities to treat diseases. Let me tell you about one particular aspect that I'm focusing on now. I've written a series, I think it's up to 8 now, on something called CAR T therapy. That's using your own cells to fight cancer. Now, it's a very difficult process. What you do is you have somebody with cancer, you identify the kind of cancer, you extract a little bit of their blood, you purify something called a killer T cell, you genetically modify that cell, and you put it back into somebody, and for the first time we're getting cures for some diseases we never thought possible. The catch, if you followed that, is it's very expensive. You're using the most expensive labor in the most expensive place, actually a hospital. And a conservative estimate of the real cost per patient is at least $1 million US. Well, can that change? And the answer is probably yes. There is now hope that a single shot can create that CAR T cell in your own body. That's not a pipe dream, that's coming to be a reality. And then the question is, how well distributed could that shot be throughout the world? Those are questions of health systems. So as I was learning about science and participating, I was fortunate to be in the right place at the right time to understand some fundamentals of the HIV epidemic and contribute at multiple levels to its current status. In fact, in some countries, you may or may not know that HIV has been effectively eliminated. Botswana is a country that has eliminated HIV as a practical problem. How many other countries can say the same? Certainly not my own. And how did they do that? They did it through systematic application of existing drugs and health systems. Without the drugs and without the systematic application, it couldn't have happened. And it also happened because of a very tight collaboration between university laboratories at Harvard and other universities and the health ministry of Botswana. A very, very tight, many, many years collaboration enabled by the PEPFAR program that George W. Bush started. Some of the international organizations, Gavi, for example, and other foundations were involved in it. But it's something that can and could be done in other countries, but is not. The next part of my journey into health was to realize that, yes, you could create fundamental knowledge, but that didn't mean that there would be solutions. A lot of those solutions are medical solutions that comes from industry, biotech, pharmaceutical companies. And so the next stop along my way was to begin to create biotech companies. And I'm fortunate that those companies have resulted in at least 6, you can count 7 drugs that have been FDA approved and are now in use. And that's been a very rewarding time in terms of translating knowledge into practice. The first of those drugs was a protease inhibitor for HIV that made a difference in whether it was a death sentence or death delayed, and now death postponed, maybe indefinitely, through a series of drugs. So it's been a wonderful journey, but I learned through that something that all of you know in your bones and why we're here today. Is there may be a medical solution to a problem, but many people will die without it, both in my own country through health inequities and because of health inequities throughout the world. And it's then that I teamed up with Dr. Reddy some almost 20 years ago. The way Access started was the impetus that, yes, there are solutions, but not available to many people. And it's not a question of can you solve a problem, it's a question of can you deliver that solution to people. And I saw some really remarkable things. Ron showed me what was happening with eye care in India, the efficiencies with heart surgery. And I began to wonder if we couldn't take some of those efficiencies, describe them wherever they were around the world in whatever system, and try to get better health for all people in my own country and in other countries. And we began with a conclave here in Delhi of, I think it was Delhi or Mumbai. Was it Mumbai or Delhi? Mumbai? Was it Mumbai? With some of the business councils. We had various eminent doctors from around the country. And the doctor I picked was Dr. Reddy, because he had the most, I think, a true dedication to bringing health care to the most people in an affordable context. And so we created Access Health to do that. And I think today with this group, it's an apotheosis of some of the hopes we had to bring together people from around the world to learn about healthcare practices and what can really work. And so it's really delightful to see you all here. And I had the opportunity to meet a few of you during the, as you were coming into the hall. But really to take your knowledge. Now, it's not easy to translate knowledge. I've written a few books on Singapore healthcare system efficiencies, elder care in Sweden, the emergency hospitals, ambulance system here in India, how a New York hospital has transformed itself from mediocre to the best in the country and maybe one of the best in the world. These are systems of knowledge, trying to create that knowledge. The problem has been people adopting that knowledge. It isn't that the knowledge doesn't exist in the world. It exists. We know how to do things very efficiently somewhere in the world. But do we share that knowledge? And even if we share the knowledge, is it actionable? I think you said action, knowledge to action, and action to knowledge, and a very positive feedback. It doesn't happen very often. I'm going to give you an example that I'm currently working on. I know that people in the White House, our chief medical advisor, the president, I think it's going to happen in our country? Maybe not, and it hasn't happened elsewhere. But I'm going to tell you a system that I saw recently, which is just one example of what can happen. And it happened in Egypt. Does anybody know about the 100 Million Healthy Lives program in Egypt? If you do, raise your hand. Uh-oh. Who's got a hand raised? Come on, I want to see one hand anyway. Chang, I know you know it. Okay, raise your hand high. Okay, Chang knows it because he works with us. Okay, you should all know about the 100 Million Healthy Lives program in Egypt. It is a remarkable system. And so the fact that you don't know it isn't your problem, it's our problem. Okay, so I'll just tell you about this one program, but there are many programs like that, like the emergency medical care system here in India. If any of us should fall ill and fall down, don't try to get a car, call 811 or 411 or what is it? 108. Call 108 and you get a free ambulance quickly. So I have many good friends in Egypt, some of them in the medical world. One of them said, you might want to, a few years ago when I was there, talk to Dr. Wahid Dos. Find out what he's doing. So I talked to him, and what he was doing was beginning a program to eliminate hepatitis C from the country. And it was done with a small grant, a $250 million loan from the World Bank that has an anti-cancer program, surprisingly, the World Bank, to Egypt. Excuse me, please. Hello, hello. A small grant from the World Bank, as I say, $250 million, to eliminate hepatitis C. And Wahid has started on his own a series of clinics to treat hepatitis C with the drugs that were available at the time. But a lot better drugs, as you know, have become available. So through a series of discussions with the companies and with their FDA, they created the following program. And it had the imprimatur of the president. So when you would travel through Egypt, and I was there 3 or 4 times looking at this program, there were banners everywhere about you should participate in the 100 Million Healthy Lives. And they deliberately circulated rumors that if you weren't participating in it and you didn't get tested for hepatitis C, you couldn't get a driver's license. And although it wasn't true, it worked pretty well. And actually, my friends, the first people who ever got tested were their drivers. Okay, and then everybody eventually was tested, everybody over 12. So how did they organize it? Now, Egypt may be a particularly easy place to be organized because it's been organized for 6,000 years. And one thing they've discovered is if anybody was a bureaucrat, it was the early Egyptians. They knew how much every farmer owed the pharaoh. Okay, every single one, they found those records. So they made piles of papyrus so that you knew who was doing what. But what they did is they created 10,000 centers up and down the Nile and other cities in which one nurse and citizens were trained to do the following: to do blood sticks, just a finger stick, to do your weight, and so what they were measuring, and to take blood pressure. And they did that for everybody over the age of 12. Military, hospitals, people who were in jail, the whole country. But what did that finger stick do? First thing, it was a antibody test. Had you ever been infected with hepatitis C? And that antibody test is pretty reliable. It cost them 50 cents. It wasn't manufactured in some low-cost country. It came from Abbott. 50-cent finger stick. That's how much it should cost. If you were positive, it costs you $5 for a PCR, the government. $5 for a PCR, Roche PCR test. That's what it should cost. Then, the next question is, what do? You were offered free government treatment for 3 months. How much did that cost? Now, in my country, the treatment of hepatitis C with 2 drugs started out at $80,000. You'll be happy to know it's down to $25,000 now, okay? It costs, in Egypt, the government $35 per person for a 3-month treatment. And that was a sustainable cost. They acquired the APIs from India, they formulated it, and they had 7 different drugs that would formulate depending on who needed what. And they found 4 million people with chronic hepatitis C, treated them all. It's about a 98% effectiveness for the first treatment. If you come back and get the rest, it's about 99.2% effective. It's eliminated the disease. You can eliminate the disease. How many countries have done that? Well, Georgia did it. The country of Georgia did it. Ask yourself, has your country done it? I ask myself, has my country done it? The answer is no. It's not a question of whether you can do it. You can do it. Many, many things can be done that aren't done. It's a question of, do we have the government leadership? Do we have the organization? Do we have the will? It's an interesting question. Would it have been done without the small loan from the World Bank? Probably not. But why not? How much is $250 million for the Egyptian government versus the other costs of treating that disease and having the deaths associated with that? I raise that as the kind of issue that this group should know about. Let's hope when you have programs like that, when your country has something that you're proud of, make sure you talk about it. While you're here, learn about the Indian Ambulance Service, the 108 service. It's worth knowing about. $15 real cost per pickup, free. I've talked to a group this big at the Jaipur Book Festival, and I asked, much bigger, maybe 10 times as big, how many people knew about it? And maybe 20 people in the audience knew about their own ambulance service. Why? They're from the upper class. They don't use it. They take their own cars to go to the hospital, and they may die on the way. Whereas the poor population has access to 108 and generally knows about it. These are really wonderful systems, and they exist all over the world. There's points of excellence everywhere. And I think that's what this group could do. So what I would say is, looking back over my career, I've been very fortunate to both be trained and to understand and to participate and learn about the wonders of modern medicine. It is a true marvel how we have invested in our research, what we're learning, the power of our tools. It's really, to me, when I look at what's possible today, it's almost unimaginable that we could do what we are doing and the speed at which we are doing it. And the availability, the way we can change the cost. I believe, for example, a whole range of medicines, antibodies and protein drugs, too expensive for most people. I believe that can be changed. I think the technology exists today to make it easily affordable. As an example, I was telling you about the cancer treatments. You could probably reduce the cost of that treatment from $1 million to $10. That's not out of the question with modern science. We can do these things. Will we do them? It's up to people like you. It's up to meetings like this, sharing that knowledge, making sure that everybody has the same possibilities that the most fortunate of us have. And I think that's a goal that we can all achieve.
Be encouraging for us in CHISD and in Indonesia that since COVID, at the very least, since 3 years ago, since the pandemic broke, conversations about primary healthcare and strengthening health system based on systems approach has picked up speed. We have been echoing the importance of intervention in primary healthcare and believe that it's not just a set of activities or level of care, but in itself is a strategy for organizing and permeating the entire healthcare system. Primary healthcare is a critical component enabling high-quality health services to meet people's diverse health needs at every stage of life, and we believe that addressing its adequate delivery is crucial. For most, the importance of primary healthcare is clear since Alma Ata, more than 40 years ago. However, in Indonesia specifically, there are many players in the effort for disease-specific intervention. The atomized approach is normalized, yet it does not exploit linkages and the interconnectedness across systems and has created health system fragmentation and segmentation. As non-profit organization, CHISD thinks differently and acts differently. I will draw to Dr. Reddy's comment about the different approach that we take. We, as a civil society, we position ourselves as the partner, the thinking partner of our government policymakers and our academician thinking partners as well. We side on the communities, we take sides with the communities, so all of our actions are based on what the community will impact and will benefit from. However, that approach has not been easy, and we have worked more or less for the whole 8 years of this organization without clear support from our partners in government, in business sector, and in the donor community. We invest in alliance building among identities that do intervention because we do not want our experience to be also experience for our other colleagues. Research, policy, advocacy, and behavior change communications are our main focus to understand and address the flaws in the current system and to have better knowledge on how to rebuild the health system. Together, we pilot, upscale, replicate solutions for service integration, driving equity, mine variabilities, scale up interventions, and assist local governments, assist community health workers, communities itself to sustain and make constant improvements. I would like to draw some examples from our 10-year journey in primary healthcare centers across Indonesia that started from 7 pilots in a team-based approach to strengthen and transform primary healthcare, which has since grown into a national scale program adopted and replicated by the government. And since COVID, we set out another pilot and has since been adopted as the system for primary healthcare transformation and strengthening in the West Java province, the biggest and most densely populated province in Indonesia. We now focus our intervention and energy also to ensure community-based strengthening and initiatives are coupled together, integrated with our health system approach to make sure communities and health system work hand in hand together. We are working in a community-based center for health, which in Indonesia is called Posyandu, and all of this integration and holistic and comprehensive approach is what we offer as part of the Learning Collaborative as a country chapter from Indonesia. Building on that, on this very good momentum this year, we want to highlight the momentum of also the 5-year anniversary of the Astana Declaration, where all our leaders commit to re-energize our efforts to improve primary healthcare. As another note, I would like to bring to the attention of colleagues here that we took the operational framework of Astana and implement that in our primary healthcare strengthening and our community-based strengthening approach. So the learning to action and action to learning has been done and for years now in Indonesia. CISD believe it's time to drive an alliance that reflects on how countries are doing with their primary healthcare improvements. However, rebuilding requires everyone to truthfully reflect on prior failures and to take stock of the current situation, which urges us to initiate a gathering of like-minded organizations to the 2023 Primary Healthcare Forum to be conducted in Jakarta on 12th to 14th of November of 2023. So please consider this as our invite to all of you to come and to continue the learning we have in this conclave there to Indonesia and to Jakarta. The forum will function as a platform for multiple development actors to keep track of the progress by monitoring the indicators by which we will measure success. The sessions will emphasize policy and practitioner dialogue, a public festival to bring PHC issues closer to communities, to have wider outreach to the whole public about primary healthcare transformation, and helping each other find solutions for strengthened and more inclusive primary healthcare. Thank you, and we thank you once again, Dr. Reddy, for trusting CISD with hosting the Indonesian chapter of the Global Health Learning Collaborative, and we look forward to a strengthened collaborations with all of you. Thank you.
Ibu Dia, you continue to inspire and you continue to share the passion to bring people to the center. We are grateful for your presence and also to consider the first chapter that will be taken forward on behalf of the GLC4HSR. I now invite Professor Mushtaq, another partner in crime, who's going to take on the next chapter for GLC in HSR, not so far from where we are in Bangladesh. But the geography always is different, as are the people, and I'm sure that we will find newer learnings over there. Professor Mushtaq, thank you.
Thank you, Uma. Distinguished panelists and friends in the audience, a very good morning. Excuse me. Still morning? Yep, of course. Sorry? Yeah. No, I have water here also. I have a bad cough, so which has been running as a kind of a side effect for COVID, I think. But it's been running for the last 2 months. I was listening to all of you, and particularly Professor Krishna Reddy, and what he said about GLC is the approach, as he said, pull the knowledge and curate the insights into actions. I'm personally a believer of this, and indeed, if you look at any of the successful public health programs in a country like Bangladesh, you'll see the use of that loop, how that has really helped to achieve what those programs have achieved, whether it is ORT or EPI or family planning and so on. Just to give you an example on ORT, as you know that the ORT was discovered or perfected in Bangladesh in the late 60s by ICDDRB. But it was not until the early 80s that this was taken to the doorstep of the people. And that was done by an NGO called BRAC, for which I spent almost all my life. They decided to teach every mother in the country on how to make ORT at home with home ingredients of salt and sugar. Initially, we thought that it would be a very easy job. You can ask the mother, you can teach her, and then she will start using that. But that was not the case. Although we are very happy that mothers learned how to prepare the ORT at home, which was safe and effective. But then within a few months of the program, we decided to do a study on how many people are using that, the usage of ORT. And to our surprise and frustration, we found that only less than 10% of the diarrhea cases were given ORT. Our assumption was that if you transfer the knowledge, transfer the technology, the mothers will start using that. But that was not the case. So we started finding out what are the reasons why there is a do-no gap there. And we found many reasons. And as we found new reasons, this was fed back to the program. And the program modified its strategy and implementation. So just to give you one example, we found that initially the BRAC program was more of a women-to-women program. The health workers were all women, and they went to the mothers and taught the solution, which obviously led to good knowledge about how to do it. But the use is somewhere else. It's a man-dominated society. So anything that involves to the extent of using a new technology, the man have to be involved, the husband or brother or the father. But this was not the case in BRAC. So immediately BRAC changed its strategy. They brought in new staff who were men. They started reaching out to the mosques, to the bazaars, and so on. And because of these innovations in the implementation, which is now called implementation science or implementation research, we now have the highest rate of ORT used in the world. More than 80% of 80% of diarrhea cases are given ORT solution. Excuse me. So this is something which is very close to my heart, and I'm very happy to be here. Also, thank you, Rockefeller Foundation, for which I worked for 4 years, and I'm happy that they are also supporting this initiative. A few years ago, the Lancet published a series on Bangladesh, and there they were talking about the kind of a paradox that Bangladesh has done so well in many aspects, but at the same, despite the issues of poverty, inequality, and poor governance. So, just to give one example is the life expectancy. When Bangladesh became independent in 1971, the life expectancy was about 45 years. But now, it has gone up to 72 years. And more importantly, the gender difference. So until the late 80s, Bangladesh was one of the 3 countries in the world, I think, where women lived a shorter life. But fortunately, this has now been corrected. Women now live 3 years more than men, which is the norm that we want to see everywhere. So, why has Bangladesh been able to do such, good thing, of course? There has been a lot of research on that to find out the reasons. And there are some hypotheses, of course. And one of the reasons is the public health actions that have been taken. I was talking about ORT, the same thing with EPI and family planning and so on. The public sector reach has also increased. And the role of the NGOs, the non-governmental organization, has played a very important role in this. Also the private sector. And more importantly, I think, is the role of the social determinants of health. So it's not only health on which Bangladesh has invested, but on the overall improvement of human development. So question of schooling, for example, education, women's empowerment, also infrastructures, right, such as the roads, for example, and also the ready-made garment sector, which sort of employs several million women, most of whom come from the rural areas. But when you look at these improvements and the reasons for that, you find that these are some of the low-hanging fruits which we have been able to do very well. Now, when we move forward, we have the vision for the SDG. We also have a vision called Vision 2041. That's the year in which we wish to be a developed country. So when we have those targets, for example, and goals, are we really moving towards that? There is a sense of complacency, particularly in the policy arena, that we have done so well. We are better than this country, we are better than that country. So there is a sense of complacency there. But in order to move forward, we need to identify and act on the high-hanging fruits. So what are those high-hanging fruits? Obviously, the issue of health systems, which we have seen during the pandemic, that we need to think about it quite seriously. We have seen that we are not moving the way that we should in order to reach those goals. For example, the maternal mortality ratio, which was about 600 in 1990s, and reduced to less than 200 by 2010. And if you look at what has happened after 2010, we see that it has actually stalled. It hasn't gone down further. So this means that we have to think about kind of out of the box in order to really identify areas which need more actions. We know that the investment in health is one of the lowest, second lowest in the world. Less than 1% of the GDP is spent by the government. So we need to work on that. Also, there is a huge neglect of primary health care. Only 25% of the total health budget is spent on primary health care. And that's the reason why we have seen during the COVID period that everybody from remote areas coming to Dhaka for hospitalization and so on, because we don't have a strong primary health care. Although we have a great infrastructure in the country, the health infrastructure, but that's not functioning well. We also have questions about the involvement of the broader society in healthcare. And if you look at the two levels, the local level and the national level, there are certain sort of design things there which sort of talks about involvement in the community at the local level through different committees, at the community clinic, at the sub-district level union health centers. But these are committees only. It doesn't sort of work. the members of parliament have been made the convener of those committees. And 80% of the members live in Dhaka, the capital city. They hardly go to their constituency, and these meetings never happen. Also, at the national level, there is no sort of similar committees as such to ensure participation of the greater community. But depending on the individual who is in charge. So, for example, when the 5-year plans are being formulated, the head of the planning commission, he sort of organized consultation at different levels, but there is no sort of requirement that this has to be done. So there is no sort of platform at the national level by the government to ensure community participation. The parliament is there, the parliamentary standing committees are there, but those don't function. There are some sort of platforms which are organized by the civil society, Center for Policy Dialogue or the Bangladesh Health Watch, and they are sort of playing that role to involve the greater community in policy making. We haven't made much progress with respect to One Health. There is a association, and that's it only. So we need to sort of involve the multi-sectoral actors in the health systems. The NGOs seem to be in crisis now because of that which is Bangladesh has becoming a middle-income country, which means that the donor support for Bangladesh is going to go down, and we are already seeing that. Also, because of the Brexit and the war in Ukraine and the pandemic, the support for NGOs from the donors has gone down tremendously, and the NGOs are really sort of facing this problem. And the attitude of the government towards the NGOs has also changed during the pandemic, when it was much needed for a sort of action on a community level, for example. But we haven't really seen that happening in Bangladesh, unfortunately. Then, of course, if we look at some of the documents of the government is talking about universal health coverage now. And if you read the speeches of, say, for example, our Prime Minister, so she talks about universal health coverage when she is outside the country. But when inside, she hardly talks about universal health coverage. But there are civil society organizations which are sort of promoting the case of UHC in Bangladesh. And as we know that like most other countries, the health system in Bangladesh is hardly resilient. We haven't been able to really face the shocks very well, and we are hardly prepared for the future. So, to conclude, I think the whole idea of the GLC, there is a huge need for such actions, such sort of implementation of this loop which will really lead us to the SDGs and also the Vision 2041. I wish to thank you again, and particularly Access Health, and of course for everybody, all of you, for inviting me to this, and we look forward to working with you. Thank you.
Thank you, Professor Mustaq. That was a big snapshot of what we can look forward to and the difference that we will make together in Bangladesh and the learnings that we will take away from there. Thank you so much. I have the privilege and honor of inviting our Technical Advisory Committee to be felicitated for the time that they have spent tirelessly over the last year to support the thought process and the entire evolution of the Global Learning Collaborative for Health Systems Resilience. Can I have that slide, please, Stuti? Quickly, can I have Ms. Shalini Bharat? Shalini ji, please come. Please come up there. Can I request Bill and Dipali to do the honors, please? Jack, Professor Jack Langebrunner. Can you give it to Bill and then you give it to Shalini, please? Give it to Bill. Yes, thank you. Yes. Give it to Bill and Dipali. Jack. Professor Mala Rao. Dipali, aap chale jao. Mala. Ida. Ida.
I think it's probably not blocked.
Professor Chowdhury Mustaq. And Dr. Shulman, Kevin. For those that are not present here, I'd just like to read their names. We have Stephen Nachuk, Professor Srinath Reddy, who will join us later this afternoon, Shuming, and Gabriel Lu, who's not here, and Sten, of course. Sten was here last month, and we were not prepared for that then. So, thank you very much. This is indeed an honor for us to have your time, attention, and constant guidance and support. And before I hand it over to Dipali, I would like Dr. Reddy to recognize those that have occupied the dais and who have been the wind beneath our wings. Dr. Reddy. There are people who are present in this room from the Rockefeller Foundation who began the journey with us. Abhinav Verma, Shubhi Vijay, and Eric, please stand up to be recognized. And we wouldn't be standing here today without the battles that we've had together to make this happen. So, I now request Dipali to please give the concluding remarks. Thank you so much, Dipali.
Thank you so much, Uma, and good morning. And it's really a pleasure and privilege for me to be here with all of you. I think it's difficult for me to summarize what was shared this morning, but I'll try to do that. I think before I do that, I just wanted to share a bit of the Rockefeller Foundation. Our vision is really to serve the well-being of humanity, and this is something that we've been doing for the last 110 years. And India and Asia have been an important geography for us, where we really seeded our public health work. So whether it's Thailand, where I'm based, where all the health institutions that you know today, we had a role to play, and even in places like China, and of course here in India with the All India Institute of Medical Sciences, Institute of Virology, and I can go on. There's just been so much of work that's been done in the public health field. Collaboration and innovation, I would say, are really part of our DNA. We take a lot of pride in being a science-driven philanthropy, and that's what we really try to push ourselves constantly towards. We also really try and see how best we can be addressing the wicked problems that we all been confronted with. Even before COVID, we all knew that the health systems were weak, and we were on this journey to really see how, whether it was through our precision public health work or other programs that we were seeding, evolving, developing, to really be driving this point home. And of course, when COVID struck, we were confronted with a situation that most of us knew of, but we really didn't know how to tackle the situation. So even before this collaborative was launched, I have two people that I want to recognize. One has been recognized already, Abhinav, who can stand up again, but Chang as well. So Chang is also part of the Access Health team, and both of them really worked very quickly to kind of put together the learnings of the early days of the COVID crisis, or what was really happening in China, and be able to share that with the rest of the world. Even in a place like India, I would dare to say, where on the border there was a crisis situation with China, but at the same time, as part of the people-to-people diplomacy, very quickly, with the help of Access Health International, we were really able to get the real-time learnings as to what was happening in China, and what was China doing to really address the problem. I think from there, the idea of really setting up this Global Learning Collaborative emerged, because I don't know whether, William, you remember, we shared the learnings globally through virtual sessions at that point of time. And that was the resounding feedback that we got. We really need to have more of these learnings. And in spite of, on the geopolitical side, whatever is happening, even now, where things have got even more complicated from the early days of COVID, we really want to be ensuring that we can come together, share, and really act very quickly. So I think that was really the genesis of what we have. And of course, Dr. Reddy, Uma, Sejal, and the entire Access Health International team, Dr. William, has just been so phenomenal to work on this particular collaborative. It isn't easy, to set up collaboratives. We all claim that we want to be collaborating, but we all know how difficult it is. I mean, for whatever reasons, it is not an easy job. And I've seen how the Access Health International team has really worked endlessly, tirelessly, to really get us to the point that we are in. So a big thank you to everybody, particularly Uma and Dr. Reddy, and also many others, Maulik, I can go on. So yes, they do deserve a big round of applause. I guess going back to what Dr. Reddy, you said, we really need to learn together. I added two other things. I said, in a nimble and agile way, because there's no point in learning 5 years down the line. I think the need of the hour, with the kind of complexities that we are facing, we need to be acting very, very quickly. So I think that's really important. And it's not just about learning together, but how do we grow together? It's not about, we're not competing with each other. We're really trying to bring about true impact in people's lives. And for that to really happen, we need to be growing together, which then should be resulting into action, because there's no point in having these phenomenal conversations, but that doesn't really get to improving lives of people. So that was something that I took away. Also, how do we really build up resilient health systems. The systems are weak. We have a challenge around health financing. We know civil society actors, Mushtaq Bhai, as you said, that are really struggling. So there are immense challenges, but at the same time, we also, how can we turn these challenges into opportunities is something that I really believe the Learning Collaborative will be able to bring to the table. I guess, moving on to what Manoj shared, around interoperability, talking about the financing issues, looking at the public spending in the region. I think there are real challenges there, but again, as I said, the only way we can address these is by coming together, really seeing where and how we can all be bringing what we have, whether it's expertise, whether it's resources, whether it's our networks. That's really going to be important. I think I really liked what you said, William, about the Christmas gift every day. There's just so much happening, and how do you make sense of what's working, what's not working? Where is it that we need to take more risks? And I think for some of us, like the philanthropic world, we do look at our resources, high-risk capital. We do have the ability to fail fast. So how do we really make that happen and ensure that, we take the first step where others would really want to have a more scalable business model that they can then take over? So I think that was really important. I think also what you said around the whole piece, reinforcing what Dr. Reddy has said about knowledge to action, action to knowledge, is going to be critical as we move forward. I think there, in terms of what you mentioned about the health system fragmentation and how we really need to be having a holistic approach, really taking on a systems lens approach, was something that really resonated with everything that we're trying to do at the Rockefeller Foundation and also in partnership with a lot of other partners with whom we work. Again, Mushtaq Bhai, the ORT example is brilliant, and I think reminds us constantly of how we need to be putting people at the center. And I think the point that you raised, which is very close to my heart, is around gender. If you really look at health issues, yes, everybody is being impacted, but who's really being impacted the most? I would want to say women and girl children. There's enough evidence and data for that. And if you're not going to make them the center of everything that is being done and really consult with them and get their perspectives, I don't think we're going to be able to really move towards building up a resilient health system. I think we'll be again continuing to waste efforts, resources, which really we can't afford to do at this point of time. So I guess with what I want to be leaving behind with this August group is we really need to put all our efforts to really making sure that our health systems are resilient. They're very fragile right now. Somebody just mentioned about climate change issues, and we're not making the intersection with health. We are seeing in a place like Missouri dengue cases that have not been heard of. In Cox's Bazar, again, Mushtaq Bhai, I heard that, for the past 3 years, there have been no dengue cases, but in the last year, there's been a real rise in dengue cases. So how do we, as part of the Global Learning Collaborative, of course, deal with the current situation, but also have a view on what's there and what is it that we need to be doing as a learning collaborative so we can get ahead of the curve and not be talking about the challenges, but really seize the opportunities, because I feel by virtue of the people that the Access Health team has been able to get together, we have the best brains, we have the best expertise, we have an ecosystem that is part of the Global Learning Collaborative. So you have people from WHO, you have civil society organizations, you have the best health experts, and I can go on. So lots of aspirations and hopes from this Global Learning Collaborative. And I think, as was said throughout in the morning, this is really a journey. This is our journey because we really believe in driving towards results to really improve the vulnerable communities who are reading with everything, whether it's the health system issue, whether it's the climate change issues. It's a difficult world in which they're living, and I think the reason that we are all here together, we really care about transforming people's lives who need it the most. So this collaborative, I hope, is going to keep that in mind and constantly keep pushing each other around, are we getting to that point where the health system is resilient to really take care of the vulnerable communities that we all care about. So thank you so much.
I can't thank each of you enough to have taken, I won't say valuable time, because this is what we all want to do together over the next 2 days. So if we are here together, it is because we believe in the learning journey that we have set out on about 1.5 years ago. And I don't think this journey is going to stop so easily. And while we started with that 1,000-mile journey with a single step, and I'm sure we know there is miles to go before we sleep. For all of you that spent that time to come here from all the way around the world, to motivate us to build back and learn better, we are grateful, and we love the fact that you're here to be a part of this journey as we go forward every day, and that you will be the power beneath our wings. Thank you so much for this session, and good morning again. And while we have tea, and we are a little run over on time for our session, please bring your tea back in and, see if we can bring the session back as much as we can.